So, welcome everyone to the Invisibly Aware series meeting. Today, we're going to be doing a presentation on dysautonomia and what it's like to live with it. We'll have some brief information on some conditions that fall under the umbrella of dysautonomia, and then have some guest speakers share their knowledge and experience with us to discuss both sides of patient care, what it's like living with dysautonomia, and what it's like treating it. So, before we officially get started, we're going to do an access check. So everyone will be doing a verbal image description of themselves, including myself. So my name is Akanksha. I am a brown woman with a dark brownish black hair. And today I'm wearing a dark blue crew neck sweater. There are also going to be available captions. So if you need them at all, you can find them on the bottom of the panel by pressing the CC button. And if there are any other accommodations needed, please let us know in the chat and we will do our best to accommodate you. So before moving on with the presentation, there are some important disclaimers that we want to give. The information we discuss during this meeting is not medical advice, and if you have any medical questions or concerns, please consult your doctor. It's also important to keep in mind that every person with any particular condition is unique. And even among individuals who have the same diagnosis, some might not have the exact same experiences as another due to a variety of reasons. Additionally, please know we are not experts on these topics. Even though we have researched them and read about them pretty well, our guest speakers are much more knowledgeable, often on their personal or professional experiences with the illnesses that we'll be discussing. So now we'll talk a little bit about what is the Invisible Illness Awareness Network and what we do. We are a 501(c)(3) nonprofit where we raise awareness about invisible illnesses, chronic illnesses, and disabilities. And we specifically support students that are starting affiliate organizations at universities to become leaders, educate their peers, and to foster inclusive environments throughout their communities. And now we come to what is the Invisible Illness Awareness Series. And so you're here, which is a great step towards educating yourself on medical conditions that you or maybe a member of your community has. The Invisibly Aware series holds one virtual event a month on Zoom at this time, and it is where our guest speaker event happens and where we highlight the lived experiences and professional expertise of those who have significant knowledge across various medical conditions. And lastly, please follow us on social media where you can continue learning about other illnesses and how it impacts people who live with them. We have the Instagrams for the Invisible Illness Network, as well as the Invisibly Aware series here, and you can check us out on YouTube to watch recordings of all of our guest speaker meetings. You can also visit our website at IIAnetwork.org, and you can scan the QR code on the screen to find the link tree for more links, including our newsletter and sign up. And please also feel free to ask questions in the chat at any time throughout the presentation. We will try to answer all of your questions to the best of our knowledge. And especially at the end, there will be time for us to answer any remaining questions or ones that we didn't get to. And with that, I'm going to pass it off so that we can begin talking about dysautonomia.
Hi, I'm Stephanie. I'm a co-founder and co-president of Invisible Illness Awareness Network. I'm a white woman with long brown hair wearing a gray blazer and a black shirt. And we'll be talking about dysautonomia tonight. So, a general definition of dysautonomia is a term used to describe disorders that affect the autonomic nervous system, which controls automatic body functions. So, things like blood pressure, our breathing, heart rate, things that we don't have to think about that our body automatically keeps track of. And it affects many body systems and causes a wide range of symptoms from these automatic functions. And there are many different types of dysautonomia. There's not one conclusive list, but there's a range of what things affect our autonomic system. And it affects over 70 million people worldwide, with many more likely undiagnosed. The 70 million number is also a few years old at this point, so we generally don't know how many people genuinely have dysautonomia worldwide. Into dysautonomia, POTS, or postural orthostatic tachycardia syndrome, is one of the types of dysautonomia. And note that this is a summary, as a general overview of what POTS is. It's not a complete exhaustive list of everything that it entails, but its general definition or diagnostic criterion, the main one, is an increase in heart rate within 10 minutes of standing, which is a 30 beats per minute increase for people aged 20 or over, and a 40 beats per minute increase from people aged 12 to 19. This has to be also in the absence of orthostatic hypotension and happen with frequent symptoms of orthostatic intolerance occurring with standing with improvement from lying down. Symptoms have to last for at least 3 months as well and be in the absence of other conditions explaining the symptoms. So symptoms can range from lightheadedness, fatigue, brain fog, fainting, blood pooling, digestive issues like nausea or diarrhea, muscle pain, palpitations, muscle weakness, headaches, among other symptoms. And it can be triggered by infection, such as COVID, by a surgery, a trauma to the body, or other medical conditions. POTS can both be primary or secondary. There are about 6 million estimated cases of POTS in the US, and this is a post COVID number. Prior to the COVID pandemic, it was estimated anywhere from 1 to 3 million Americans affected with POTS, but that has since more than doubled since the pandemic has happened. And the last form of dysautonomia that we'll be discussing tonight is autoimmune autonomic ganglionopathy, otherwise known as AAG. So the general definition is it's a type of dysautonomia where the immune system damages a receptor in the autonomic ganglia, a part of the peripheral autonomic nerve fiber. And autonomic ganglia are clusters of nerve cell bodies within the autonomic nervous system, and they act as junctions between autonomic nerves. So basically, it's our immune system damaging the receptors for these nerve cells, and this causes signals to be processed incorrectly by the body, impacting our autonomic nervous system, our automatic body functions. And symptoms can include severely low blood pressure upon standing, fainting, gastrointestinal dysmotility, so improper movement of the GI tract, urinary retention, so not being able to expel urine, fixed and dilated pupils, dry mouth and eyes, and it's a rare condition. Less than 100 Americans are diagnosed with AAG each year. And we're lucky to have a guest speaker being willing to talk about their experience with AAG. And with that, I'll pass it on to Morgan to introduce our guest speakers tonight.
Alrighty, hi everyone. And so my name is Morgan. I am also a white woman with long brown hair. I am wearing a white crew neck sweatshirt. Thank you so much to our guest speakers for being here to talk about their experiences tonight. We're really excited to hear from you all and to get to know a little bit more about your conditions and your experiences and background. And again, either being a patient or treating the conditions. So firstly, I'm just going to go through and quickly list off who we have here with us. So actually, before I introduce you all, how about I have you guys just say a quick hello, just say your name real quick, as well as your handle on Instagram if relevant, or again, just your general title for Dr. Boris. And we can
I,
start with Iman, if that's all right.
yeah, that's totally fine.
Oh, sorry. I'm sorry, I didn't even hear you speak.
Oh no, you're totally fine. I was like, who's going first?
Hi, my name is Iman Rahman. My pronouns are they, she. I am a brown person. I'm wearing like a kind of a mauve shirt. I have short black hair, and you can find me on Instagram at a little bit of faith.
Wonderful. And then Maggie.
Hi, I am Maggie. I am a white woman with kind of shoulder length brown hair, and I have this really cute olive green shirt on, which I love. I always get the chance to use it for when I get to be on video. So, but I also have my sewing stuff behind me. If anybody's curious about what I have in the background, I have a mannequin here behind me and. A cute pink cutting mat and all that. But yeah, I have been a AAG sufferer for a while now, and I'm sure we'll get a little bit more into that later. But yeah, just wanted to say a little hello and just kind of describe my surroundings for anybody that needs it.
Alrighty, and then Dr. Boris.
Hi, I'm Dr. Jeff Boris. I am an older white male, clean shaven, wearing glasses, short brown hair, and green and tan plaid shirt. And as the screen says, I'm a pediatric cardiologist and also pediatric autonomics specialist. I've been taking care of POTS patients since 2002, probably cared for over 1,200 POTS patients in my career. I'm presently in private practice for 5 years now. Telemedicine only practice, licensed in multiple states across the US. And I've also published a number of research papers in the field of POTS as well.
Wonderful. Well, thank you all so much again for being here. I'm really excited to get to know a little bit more about you. So I'm going to go ahead and jump into our first question here. So thank you again for introducing this. This first question here is going to be specifically for our patients. So I was hoping if you all might be able to share your experiences living with an invisible illness, chronic illness and or disability, especially related to dysautonomia today. So maybe when you started experiencing your symptoms, what type of symptoms you might have had, as well as maybe a brief condition of how this condition has affected you. And we can start with Maggie.
Oh, sure. I also forgot to say my Instagram is GumiV4. But in terms of how my dysautonomia has impacted me, it's impacted me both physically, obviously, but also mentally a lot too, because my symptoms first started when I want to say I was about 13 or 14 is when the very, very minor symptoms just kind of started to creep in. And I'm actually a type 1 diabetic as well. I was diagnosed with that when I was 7. And in terms of getting diagnosed, it was really difficult because that was really all the doctors saw was just strictly the diabetes. That was what everything was getting blamed on. Um, so just day-to-day life, at least in terms of that chunk of my life of trying to get diagnosed. It was really, really hard. It was, just mentally like I almost felt like I was gaslighting myself. I'm like, oh, maybe there's nothing wrong with me. Maybe the doctors are right. I'm just not taking care of my diabetes well enough. And, because again, 13, 14, I was a teenager during this time. And, teenagers aren't gonna eat the best or, take the best care of themselves. So at least just in terms of trying to get diagnosed, and it created a lot of doubt in myself. And I think my day-to-day life, in terms of, kind of getting over that doubt while trying to kind of give myself some grace in terms of dealing with my symptoms as well has been, kind of a balancing act, if you will. But I think that's kind of the best way I can describe it because I feel like a lot more mentally again challenged versus physically sometimes, but it just kind of depends.
Yeah, thank you so much for sharing. And then Aman.
And would you mind repeating the question?
Oh, no worries at all. So if you just wouldn't mind sharing a little bit about your experiences living with dysautonomia. So for example, when your symptoms started, what type of symptoms did you have, as well as just a brief description of how this condition might affect you.
Yes, so I actually was thinking that I have been diagnosed with POTS since like 2016. But then I also got diagnosed with a different type of dysautonomia, vasovagal syncope slash neurocardiogenic syncope, and that one has been more um of my newest experience, I guess. So I did have symptoms as a child with POTS and with these things, both of them, honestly. I just was not very aware of it, and it was kind of dismissed. I was passing out, having to run the mile every week in school and things like that. And they were just like, oh, just wait until you can get up again every single week. And I just kind of was like, no one else is going through this, but I guess, it's okay. And then as I got a little bit older, it became more intense. It was affecting me more often. It was hard to ignore. Um, so in terms of the vasovagal syncope, I guess for me, it was hard because I was starting to have a lot of my blood pressure dropping when I was laying down. And so they were like, that's not POTS. I can't be POTS. And I was like, yes, but what do I do now? Because it still is something going on. So I was struggling a lot with that in terms of how it was affecting my life. It was really difficult because before I was experiencing a lot of pre-syncope, and then all of a sudden it was like, oh, now I'm actually going through fainting all the time. But it's so unexpected for me, and I didn't know you could faint even just by lying down and just fainting while lying there instead of like having something trigger it that was physical. Um, yeah.
Yeah, thank you so much for sharing that. I'm so sorry to hear that you've been going through that, but I'm happy to hear you have some answers to what was going on there for the both of you all. And
And that,
then,
yeah, that kind of ties into the next question. Would each of you mind sharing how you got diagnosed? Share a little bit about your journey. Things you might want to talk about is like how long did it take you to seek help after noticing your symptoms for the first time? How long and how many doctors did it take for you to receive a diagnosis, and a correct one? And what was your emotional reaction like to receiving a diagnosis? Like Maggie mentioned, it can be both an emotional and physical process, obviously.
Yeah, I mean, honestly, in terms of, again, I kind of went into this a lot in my, previous answer because you guys already went over kind of some of the symptom stuff when you were doing the introduction. So I was like, oh, I'll talk a little bit more about how it actually affected me. But kind of leading back to that, it was kind of it was hard to kind of seek that help at first because even myself I fell into that rabbit hole of like, oh, it is probably just my diabetes, and my blood sugar is all over the place because they it genuinely was all over the place. And so I was like, okay, I'll just try a little harder. We'll tweak my insulin and we'll go from there. But then my symptoms just started growing to the point of like, this isn't diabetes. This is not a typical sign of diabetes. Like for example, like I was just blinded in the sun. I still am. Like I can't, I have the delayed pupillary response. So that was just something that we were like, "Ah, I don't think that's really, related to the diabetes." And then the just the severe fatigue. At this point in time, I was probably about 16, 15, 16, when that really severe fatigue started to kick in. And which, fatigue can be a sign of, or be a symptom of diabetes and that out of control blood sugar, but it was just at such an extreme that even my parents were like, we've been raising this diabetic child for years now, literally half her life, and she's never had fatigue like this. She's complaining of pain now, and they're explaining this to the doctors. And they, at the point that we did finally get help, and again, I kind of explained how I was just kind of brushed off. But luckily I finally found a doctor that was willing to say, like, hey, this is not endocrine related, like we need to send you to Stanford. So they actually sent me, or well, she said that it could have been oh my gosh, endocrine related, but it just was not. She just was just out of her scope of field, basically. And so I was sent to the endocrinologist at Stanford, who then was to say, yeah, this isn't endocrine. And then I was sent to a neurologist at Stanford, where I was able to get that final diagnosis of the AAG, because I was, given the proper tests and stuff, and they saw that those ganglionic antibodies were just through the roof, like way, like that's not normal, like at all. So that was when I was able to finally get my, diagnosis, that hallelujah moment, quite literally.
Yeah, that's definitely a roller coaster of going through a lot of doctors, but I'm glad that your first doctor recognized that she couldn't help you in the way
Mhm.
that she knew you needed and, you know, gave you to people who could.
Definitely.
Um, should I go now?
Yes, of course, Iman. Sorry.
Okay, no worries. Well, it's actually kind of funny because I actually went to Stanford too. I also was 16 and I was getting sent to Stanford Pediatrics, and they eventually were like, "Oh, well, we still want to send you to the adult side." So I saw a neurologist, and interesting experiences with this person, but I did get diagnosed with the tilt table test for my POTS and things. And it was kind of interesting because I was actually there for chronic migraine, and then he ended up noticing this. So I didn't even know about POTS, and he was like, "I think we should do this too." Once the other vasovagal syncope thing was happening, though, it was like almost my POTS was like the same kind of thing of like the pre-existing condition. Let's blame it on that. There's nothing else going on. There's nothing else going on. And for me, I was having symptoms that I didn't really usually have. Like I was having a lot of like convulsing when I pass out, and they weren't sure if it was seizures. They weren't sure what it was. So I went to the ER. I tried to talk to my doctors. I get like a bunch of testing done, and they were like, "No, thankfully nothing is wrong, like with your brain, like more serious types of things." But it was really difficult because I didn't really know what it looked like when I was passing out. I didn't really know what was going on, and we wanted to make sure, be safe about if this could be really something serious. And I did end up getting help once I saw a cardiologist. What my neurologist wasn't willing to do, my cardiologist was willing to like up some of my meds, and it helped a lot with managing my blood pressure. And that was really what helped me and really getting validated and heard by a doctor that was like, yes, even if it isn't POTS, even if you already have POTS, you could have something else on top of that. So instead of telling you, like, yes, you have this going on and it shouldn't be happening when you're not moving around. Let's address that it is happening while you're laying down and like what can we can do about that, because that makes things even more hard to deal with than it already is when you're worried about like, moving around, triggering a blood pressure drop and everything. Because for me specifically, my blood pressure is affected with my dysautonomia. So, yeah, it took a couple doctors, but it mostly took a lot of time in between trying to get them to see me, trying to get a doctor to be willing to hear me out, trying to even figure out how, if they would like get the testing ordered, if they were willing to like help me. So yeah, it took quite a bit of time.
Yeah, well, I'm happy that you both were able to see the specialists that you needed to see to get the diagnoses. But I find it really interesting the similarities in your story, obviously with Stanford, but beyond that too, just how you both had pre-existing conditions that kind of influenced how you received care in the future. And so I think it's really important for patients and providers to recognize a lot of these conditions can be more comorbid, and it doesn't just mean because you have one thing, oh, we should disregard everything else. It's we should still investigate things just as thoroughly as they might be, irregardless of that initial condition. So, wonderful. I guess I have a quick question for, yeah, I guess Dr. Boris here. If you wouldn't mind just kind of talking about what the diagnostic process looks like in relation to POTS, or not, sorry, POTS specifically, but dysautonomia in general. Do you normally take into consideration some of these other conditions, or what does that look like on the provider side?
Sure. I think that so much is dependent upon the history. So much, and number one, and number two, so much is sadly dependent upon the knowledge of the person asking the history. And after 23 years, I continue to recognize that if you don't ask, you won't find it. And so the more things you ask, the more you realize, oh, that's happening too, right? And so, initially, if I have a patient who is referred to me for lightheadedness and or syncope, what I will do is I'll get a sense of how often it's happening, how severe it is, how much it's adversely affecting their day, um, and their ability to do their activities of daily living. How much fluid they drink on a daily basis, how much salt they take in on a daily basis. Are they skipping meals? Patients who have sort of typical vasovagal syncope, actually, I should call it neurocardiogenic syncope. Typical neurocardiogenic syncope either don't have enough fluid intake, don't necessarily have enough salt intake, or skip meals. And about 85% of the kids whom I see who have lightheadedness plus minus syncope are fixed with that, which is kind of cool. Easy. But another 15% need medications. Certainly from a POTS standpoint, and even from an AAG standpoint, I will be completely honest, I've probably in 23 years not had a patient with AAG because it is so uncommon. Um, eh, but um, the POTS patients have much more severity across many more body systems. So unlike the cardiovascular issues where you get lightheadedness, you might have a little blurry vision, you might have some buzzing, ringing, roaring, muffled hearing, maybe a little nausea, maybe feeling hot or cold, heart rate going really fast or really slow, maybe a little bit of sweating, and that's about the symptomatology um, lightheadedness, or typical orthostatic intolerance with that, with or without syncope. The POTS patients, way more. Oh, and by the way, for the lightheaded, regular orthostatic intolerance patients, the rest of their day is fine. They can do what they want to do. They can exercise, they can go to school, they can hang out with their friends, they can do whatever. But the POTS patients, not so much. And so and as I said, it covers multiple different systems. So from a neurologic standpoint, not only do we have headaches, we have severe fatigue. Slept 10 hours last night, woke up, feel like I haven't slept at all. Brain fog, can't think, can't concentrate, can't remember. Um, Insomnia, that kind of thing. From a GI standpoint, nausea, plus minus throwing up, diarrhea and or constipation, bloating, abdominal pain, early satiety, meaning really hungry, take a couple bites full. From an orthopedic standpoint, muscle pain, joint pain. So it's it it's really understanding that there is there is a spectrum of symptoms that you have to kind of think about when you're thinking about these various diagnoses. And then the other thing is, because at least with POTS, we don't have a a biological marker that we can just draw a lab and say, like for with AAG, for example, you can find that absolutely those ganglionic antibody levels are hugely elevated, right? And that's not supposed to happen. That's not supposed to be there at all. With POTS, we don't have a blood test, right? So we're still using a clinical diagnosis plus the use of either a tilt table test or a 10-minute standing test. And I'm going to modify the definition that was given initially. It's not just an increase in the heart rate in the first 10 minutes of upright position, it's a sustained increase in heart rate in the first 10 minutes of upright position. There are a lot of patients who have something called immediate orthostatic hypotension, where they stand up, they get a little bit of whoa, a little dizzy, a little dark vision, blurry vision kind of thing, and it's gone within 15, 30, 60 seconds, and then they're fine. That's IOH. And their heart rate may go up 30, 40 points. That's not POTS.
Yeah, I can definitely see how it's kind of hard to tease apart all of this. There's so many ways that dysautonomia can manifest. And so trying to figure out what's contributing to what symptom exactly and what might be a comorbidity as opposed to the initial presentation sounds super, super challenging. So I really appreciate you, Dr. Boris, giving some of that insight on what it looks like from the clinical perspective and what type of points you all tend to focus on and questions you look to answer. So thank you for that. For our patients, real quick, I'm curious to hear a little bit about more about how your day-to-day life has changed since you have developed your condition. So, for example, what challenges do you face on the day-to-day basis? That can be physical, that can be emotional, that can be socially. I know we touched on some of those factors. What also has this condition maybe taught you about yourself, or as well as maybe how it's influenced your view on yourself or your identity in some ways? I know that's a lot of questions, so you don't need to answer all of them, but maybe just pick a few and just kind of describe about how you have maybe been affected.
Again, at first, like that for that first question, I really like wanted to talk about the mental kind of side of things first, because I was like, if somebody comes into this Zoom meeting, like, and they only hear one thing I have to say, I want them to hear about, how medical gaslighting and just that ignorance, I feel like, from some doctors can really affect, people. So I won't go over too much of that again, since I already did go over that. But just physically as well, I sleep at least 10, 12 hours a day, because my body, it's constantly fighting with itself. And my doctor, that's what he said, that a lot of my fatigue and my brain fog is from. And I tend to lose track of my train of thought a lot as well. And he said a lot of those things are being contributed to from the AAG, just because, my immune system is literally attacking parts of my nervous system and my, ganglion nerve. Like it's just like a whole mess. And so it's causing that really severe fatigue, which I think for me is probably the worst symptom that I struggle with, in terms of just severity. Um, but also just like pain, and then also like the lights and stuff like I had mentioned. But it's just learning how to juggle all of these like moving symptoms and all of these just moving parts of having such a rare illness like this, especially because there is not a one size fits all treatment for this. And you guys haven't asked about treatment, so I won't get into that quite yet. But the treatment that I'm currently on, it does tend to help quite a bit. And that's another reason why I had originally only gone into kind of like the mental side of things, because my physical side effects kind of fluctuate. So it's hard to say in a solid answer like this is how I feel 24/7. But I will say the fatigue is probably the one thing that is more or less consistent for me in that department of just like physically from a day to day.
Yeah, definitely. The mental load of just trying to figure out how to navigate your condition. And then on top of that, feeling like you can't fully participate in things the way that you would like to. So I
Absolutely,
definitely understand.
yeah.
Yeah, perfect. And then Aman?
Well, I feel like the biggest part for me really was just having these episodes several times a day for like over a year, and how that really led to me feeling worse and worse without having management of my symptoms. And trying to get help. And it was really difficult because I mean, when you pass out all the time that often, it really feels like your brain doesn't work the same way anymore. And so I feel like what I'm grieving the most right now is how my brain works compared to before, and how it's so much harder for me, like you were saying before, to have the brain fog. But it's like a different level for me now, where like I have issues with short-term and long-term memory, but also I barely remember when it was at its worst because I was just always passed out. So it's like hard to recall what I was going through because a lot of it I wasn't conscious for. And there was this feeling of, being scared that a lot of people could use that against me. Oh, this happened and you just don't remember. Or, the gaslighting of like someone telling me that I didn't do something that I should have and I just couldn't remember. So like it was very easy to convince me of things, and it felt very unsafe. And I'm still navigating processing all of that now, even though it's more managed now. It still does take up a lot of my mental and emotional capacity just to process how traumatic it was, but also like the effects from after, even now that it's finally been addressed a little bit more. And again, like I also won't go into treatment too much right now, but like I think that in terms of daily life, I'm still trying to navigate a lot of the changes that Dr. Boris was mentioning, of like it is very long term for me. Like I don't just have it go away after a few minutes. It's like days. It affects me for long term. And it's very difficult because sometimes the episodes when I do pass out, I have I come back from it very quickly, but the symptoms linger. And it's difficult to really notice all of that while I'm feeling disoriented from coming back from passing out. So it's like this very complicated feeling of grief and trying to recall everything while feeling kind of foggy during it.
For sure. And you brought up like a very major thing that a lot of people don't really think about when they think about chronic conditions or dysautonomia or things in general, is like the grief and kind of coming to terms with this is my life now. I can't really remember the before. This is what I deal with every day. And how do I come to terms with that and, make it something that you can live with and not just survive with, but, hopefully thrive with eventually. Thank you for sharing that. So, I don't think we've touched on this too much yet. For patients, what have you tried that's worked for you to help relieve some symptoms? What hasn't worked? You don't have to list everything that you've tried under the sun, but maybe some more notable things that maybe you've heard from doctors to try that didn't work, or just people with your condition in general, what works and what doesn't work for you personally.
Oh, it says we will answer this question at the end on the thing. Do you still want me to go ahead and answer that? Oh,
Yeah.
okay. Oh, okay. In terms of treatment, at first it was symptom management. That was kind of our first route of treatment because I don't think my doctor quite wanted to jump to infusions, which is, essentially the route that we did end up having to take. But after just like taking pills and whatnot didn't take away all of the symptoms. I mean, it helped lessen like the pain and whatnot, like because I have like muscle and joint pain, like when I have really bad flare-ups. But when it helped with things like that, it still didn't help with things like the fatigue or the gastroparesis or my eyes. It was if I wanted to nail all these points, really, we had to move to the infusions. And we first tried IVIG plasma, which actually led to me getting aseptic meningitis one time. And I had really severe fluid buildup in my head and my spine. And I will never ever forget that. But after that, still didn't do much for me in terms of symptoms. We finally moved to doing an immunosuppressant like chemotherapy essentially to get my immune system to stop creating those antibodies that are attacking the ganglionic nerves, and that has honestly been like my saving grace. It's been hard trying to figure out like a good cycle for it. That it took like a good year to figure out how often I needed to do it, like because how often or how quick the medication would leave my system. I'd then have like these 2 months, or because we originally did like six month intervals, and then we were like, hey, it's leaving too quick. Let's move it down to like 3 month intervals, which is what I currently do now, and it's been again my saving grace when I can actually get it from my insurance.
Maggie, do you mind if I ask which immunosuppressant you're taking?
Oh yes, it's Rituxan, or it's like rituximab.
Thank you.
Yeah.
Thank you for sharing. I'm sorry to hear about that
No,
experience you
it's
had though
okay. It's
with the
okay.
meningitis, but I'm glad
Thank
you're okay
you.
now.
Yeah, thank
And
you.
And I'm glad it's been the immunosuppressant has been kind of like your saving grace and everything. That's a relief for
Oh
sure.
yeah, definitely.
Iman, do you have some things to share?
Sure. For me, I think a lot of it was symptom management as well, learning what my triggers were. I've also, from other conditions like that I deal with, I also use mobility aids quite often. I have a wheelchair that I use for long distance. Sometimes, a lot of the time, I use a cane. Um, Using mobility aids has really helped me. Just keep the symptoms a little lower. It doesn't make them go away, but it does help me do a little bit more. Um, and then I did mention the blood pressure medication and trying to adjust that. Currently, we're trying to get my blood pressure more managed so that I can be on some beta blockers in the future, possibly. I haven't been able to because my blood pressure's been too low to safely be on them. Um, so that is something that I'm working towards. And then, yeah, like I mentioned, I think a lot of it really is like making sure that I have like temperature regulation things with me. So like I have a lot of ice packs, sometimes I have heat, just making sure that I can kind of work with the different symptoms, but knowing what it looks like for me when I go into um syncope is really helpful for me now to know like what that looks like, what to prepare. Oh, I'm getting like hot. Let me grab an ice pack. Like, let me drink some, like you were saying, need a lot of fluids. I do have gastroparesis and some other things that make that difficult, but like still keeping mind of that. Maybe taking some salt tablets, like having those things on hand preventatively, but also like once I notice, oh, there's signs of these, like let me try to beat it. Um, some of that can help manage at times. It doesn't always work, but just learning those things and being able to acknowledge what's going on helps me kind of prepare and even manage for after an episode as well.
That makes total sense. It's a lot of trial and error, try to figure out what your body likes and doesn't like and when and how. So that makes a lot of sense.
Yeah, definitely. Alrighty, so going to our last question for our patients. So, if there's one thing that you want people to take away about your condition, so whether that's like the public, maybe it's other people who think they might have your condition, or maybe it's even healthcare providers, what would you say that one thing might be? And try to keep it to maybe a sentence or two, if that's okay.
Honestly, I mean, I feel like this series is really helping that, and it's just don't judge a book by its cover. Invisible illnesses are very severe, and not taking them for what they are can like lead to having, like what happened to us, taking so long to get these diagnoses.
I think that's an excellent point. Thank you for sharing. And then Aman?
Yeah, I think trusting yourself, like it's really, really hard, with the gaslighting that happens, but also like how we gaslight ourselves as well. Like it's hard to learn to trust yourself, but the more I learn continuously, it's like, oh, wait, I know a lot about my body and like I am the one living in my body. So like remembering that you're the one who experiences it and you're the one that knows best in that way.
For sure. And it's hard to show yourself grace sometimes in figuring things out and getting, a handle on everything because it's a new experience. Everyone has to start somewhere and it's always a work in progress. But something we like to say is you never always be kind because you never know what someone's going through. It could be an invisible condition, it could be someone lost a family member, it could be a financial trouble. You don't know what's going on in everyone's life. So just, be kind, have grace for as many people as you can, and just keep working through life. All right. So we do have some questions for Dr. Boris. Um, you already kind of spoke a little bit about your background and what you've been doing and treating POTS patients for so long. What drew you to pediatrics specifically and as a pediatrician and a pediatric cardiologist?
Hmm.
And what drew you to working with POTS patients?
So pediatrics specifically, when I was in medical school at Washington University in St. Louis, your third year of medical school, you rotate through kind of all the basics, right? So OBGYN, pediatrics, internal medicine, surgery, and then sort of this mishmash of ENT, ophthalmology, and psychiatry. And um, I and so I did OBGYN up front because I knew I did not want to go into that. And if I screwed up, who cares? Because that was early. But it was paired with pediatrics. And at the time, I was scared to death. I mean, I don't know, like, what do I do with a kid? And after a week or two of doing pediatrics, I'm like, I know what to do with a kid. I are one. Um, and it, and then while I was doing my rotation, I thought, so, okay, taking care of kids is fun. Taking care of adults will be funner because they can talk with you and they can discuss with you. They can have a nice conversation with you. And I realized very quickly after rotating on internal medicine that taking care of adults was not all that. That you have people who have self-abused in one way, shape, or form for 25, 30 years, walk in the office and they're like, Doc, make me like I was 25 years old. I'm like, there's the door. So I realized that pediatrics was kind of my gig. And then on top of that, when I was doing my pediatrics rotation, um, uh, at WashU, I actually diagnosed a congenital cardiac defect in a patient that had been missed by everybody. And I was like a medical student, and I was just doing this thing. I'm like, that's kind of cool, right? If you do a careful examination, you can actually find and make a diagnosis, or at least have a good differential set of potential diagnoses for congenital cardiac disease. So that sort of started me on the whole cardiology pathway. And then, so fast forward, I did my training, and in 2002, I'd been already practicing for about 5 years, and I had been taking care of a lot of patients with syncope, and really, had been pretty successful with it. Had a patient come in with lightheadedness and a little bit of syncope, and I was like doing my usual stuff, and she wasn't getting better. And I'm like, what the heck? And after a while, I was like, well, I've heard of this POTS thing. I wonder if it's that. And so I looked in the medical literature, and this name kept coming up. Uh, the name of an adult electrophysiologist, a cardiologist in Ohio, Dr. Blair Grubb, and I cold called him. Hi, you don't know me, but and we talked for 2.5 hours, and he taught me a lot of stuff, and we are still very good friends now. And so that sort of started me down that road. Um, I had been taking care of a few POTS patients in the Air Force because the Air Force paid for med school. I was in private practice for about 3 years in a group practice, left there, went to the Children's Hospital of Philadelphia, and told the clinic nurse manager, by the way, I know how to take care of POTS patients. And her response was, are you sure you want to tell me that? And not long after that, the heavens opened. My colleagues started sending them, the gastroenterologist started sending them, the neurologist started sending them, and they were way more complex than any of the patients that the POTS patients I'd previously seen. And so once I stopped hyperventilating myself, I consulted with a bunch of colleagues and did a lot of reading and just tried stuff. Let's see what happens. But I mean, in conjunction with the patient, we're going to try this low dose. Here are the potential side effects. Let's see what we can do with you. And I continue 23 and a half years later, I continue to learn from my patients. They teach me all the time.
Wow, that's incredible. I feel like you're the physician everyone wants to have on their care team because you're someone who's curious to learn more and you're trying to educate yourself and look for all these answers and figure out, again, in partnership with your patients, what's going to be the best treatment. So that is incredible to hear your story and how you got to where you are currently.
Well, and it's
Um,
and it's sad because I think, I've seen some of the comments in the chat, and as well as what both Iman and Maggie have gone through, and so many physicians um, are they sit there and say, well, I'm a cardiologist and there's nothing wrong with your heart, so you're fine. Or um, I don't know what's wrong with you, or it's anxiety,
right,
or you're making it up. And then on top of that, at least from a POT standpoint, and also from a syncope standpoint, and I'm not sure from an AAG standpoint, but the large majority of patients um, are female. And unfortunately, in the medical community for decades and decades and decades, females have been marginalized and gaslit. All you have to do is go back to the 1950s and 60s and look at the diagnosis of hysteria, right? That was a diagnosis, okay? But then CT scans came along and people started looking at these women's brains and like, oh, there's really something wrong. That was multiple sclerosis. Okay. And so it continues. It continues today. I think the other thing too is so many physicians today get to a point in their career where they're like, I know everything I need to know to take care of the patients whom I'm seeing in my clinic. And if you don't fit in this little box, then it's nothing that I can deal with, and it's your fault. Wow. Really? Then why are you in medicine?
right, right. Thank you so much again for sharing. I'm curious to hear, obviously, you mentioned you've been in practice now for 23 years. How has your understanding of POTS and dysautonomia in general changed from when you first started treating patients
Yeah.
back in 2002?
Oh my God. So I will say that so many things. First of all, at minimum, and again, I have to thank my patients for teaching me various things that I now incorporate into my practice, certain supplements that or like salt supplements and certain other things that I do to help them to reduce their symptoms. I think there has been incredibly increased understanding about sort of the symptomatology of POTS and the comorbidities of POTS that I didn't realize. I mean, and I can tell you that a decade ago, I'm sure a ton of patients fired me because I wasn't, for example, diagnosing one of the significant comorbidities, mast cell activation syndrome, right? And so I think knowing now how to diagnose and manage MCAS, that has made a huge difference for a lot more patients, right? I think there's been other research to suggest that POTS for a lot of patients may be autoimmune. We haven't proved for most, if not all, we haven't proven that. I'm hoping that there will be research in the next 10 to 20 years that'll kind of get us there. And so it's really been a recognition that we can't make POTS go away, right? And so I actually published the first of our long-term outcomes survey papers a year ago, this past summer. It was a humongous survey that looked at over 225 of my former patients. And one of the many questions that we looked at was persistence of symptoms. And unlike the 6 prior long-term outcomes studies that had been published, we found that suggested that POTS goes away. We found that 99.1% of POTS patients were still symptomatic last month, with an average duration of symptoms of 9.5 years. So, and there's actually some preliminary data out of Calgary in Canada with the same kind of findings in adults, but more like 20 years. So, I mean, I think there has been forward progress, forward understanding. It's slow. It's slow. I think amongst even us quote unquote experts, there's a lot of disagreement on how these patients should be managed, and which unfortunately doesn't help the patients or families, because I think um, uh, some patients have really pretty good results and are able to function, and some patients are only marginally functional.
Yeah. Thank you for sharing all that. Kind of speaking of your, you mentioned research towards the beginning and what you've been doing. What do you think is the most interesting thing that you found in your research that you're allowed to share at this time, on POTS in the last few years as we keep learning new things?
I think one of the most important, honestly, and not that I wanted to necessarily show this, but I think one of the most important things that the patients knew and the doctors didn't want to know was that POTS doesn't go away, that we haven't, that because we don't understand the underlying pathophysiology or pathophysiologic mechanisms, POTS doesn't go away by itself. And I think showing that was probably one of the most important things that has come out of our of my research. Certainly, I've looked at a lot of my research is sort of just cross-sectional analyses of what kind of symptoms do my patients have? How do they do with various medications, therapies? What what is the prevalence of comorbid joint hypermobility? What is the prevalence of comorbid MCAS? I actually have data in my present clinic, so about 5 years, over 270 patients, to suggest that in the setting of POTS, 78% of patients have joint hypermobility. So it's not all, but it's a lot, right? And 71% probably have mast cell activation syndrome, which is huge, right? So, we're getting there. We're getting there. But I think from my specific research, I think those are kind of the things that are the biggest issues that I think have been important and most interesting to me.
Yeah, definitely. Thank you so much for sharing. Do you have any suggestions on people can help? Oh, sorry. Do you have any suggestions for how people can help others to understand POTS and how it actually affects patients? Because I know obviously that's kind of what we're trying to do here is bring awareness and education about what conditions like this look like. But do you have any suggestions beyond that of some things we can do to educate others?
I think it's hard from an individual patient-based approach. I think that for better, sadly, doctors have a lot of ego and certainly don't want to be taught by a patient, you know. I think what so my thought on that is, work with the patient advocacy and support groups because, for example, and full disclosure, I'm on the medical advisory board for this group, but Dysautonomia International has worked very hard to increase um, education of physicians and nurse practitioners and physician assistants around the country, and they're working to try to change to increase at the medical school level, right? And increase education on this at the medical school level because people have that front loaded, and I think we're otherwise not going to get anywhere um, uh, if it's sort of onesie twosie, how can I as an individual person try to teach this physician how to do that? Because they're just going to blow you off. Um, but I think the larger advocacy groups, um, have been helpful with that.
For sure. And there's so many different providers all across the country and across the world. It's like you can't personally teach and talk to every single one of them. It's like it has to start at some sort of systemic level where we need to like address the root cause of why we're missing these things in the first place. No one can know what they don't know. Like we need to start at an educational level too.
Well, I think the other half of that is people don't want to know what they don't know because that means that is an insult to their self, right? That's an insult to their education. That's an insult to their abilities. It's hard.
Yeah, I have seen more of a pattern in medicine of people, being willing to work with patients more and wanting to learn. At least in younger generations, I work with some residents and doctors, and just being willing to listen and know and address the fact that they don't know everything. It's no one can know everything. That's why we have specialties. That's why there's doctors in specific areas because you can't know everything, and it's hard for people to accept. But always a struggle to want to learn more, but you can't learn everything. Um,
Well,
but
but I think so. The response to that is that the response that should come from the physician is, I don't know, but I can get you to someone who does.
Mhm. Or like what you did with working with POTS patients as you grew to learn and
Just
understand
do
more
it.
over time is
Just
yeah,
do
work with
it.
them, do it, try to figure it out with them. Be like, I don't know, but I want to try to figure it out with you. And that's a huge thing from a patient perspective. It's like that's a lot of times what patients are looking for. They're just looking for someone to listen and to try to help. They just want to be acknowledged and
Oh,
obviously help with their
validation is so
symptoms.
important. The
Yeah.
validation is like half the battle won right there.
For sure. Um, Yeah, that's a good kind of wrapping up question, Morgan. One I do want to ask though, uh, how do you think the pandemic has influenced how people see and understand POTS with things like long COVID coming? And has it brought any positive and negative attention to dysautonomia and autonomic conditions? And how has it influenced your practice as a physician?
Yeah, so it's interesting. Pre-pandemic, the estimates, and I think you all mentioned this, the estimates in the United States of affected POTS patients was about 1 to 3 million. Post-pandemic, it's probably 3 to 8 million. And as long COVID was being recognized, and as long COVID was realized to induce POTS, MCAS, MECFS. My thought was, I feel really bad for these patients, but by the same token, this is really going to improve the research. It's really going to bring more people into the field to try to take care of these patients. And so there's a little bit of a silver lining. From my own practice, have I seen patients who have had COVID induce POTS in them? Sure. Um, the typical age range that's listed in the literature is between 20 to 40 years of having long COVID based POTS. But I still treat it the same. And it typically, responds the same as POTS that was induced by Lyme disease or by Epstein-Barr virus or by a concussion or by, a growth spurt or menarche, onset of menses, all of these things have been found to be triggers for POTS, and the therapeutic approach is still the same for me. It's just interesting that a lot of people have more showing up post-COVID from that standpoint.
Yeah. I'm sorry, Stephanie.
No, you're good. I was just gonna say that's interesting. Thank you for sharing that. And
Yeah.
I think Morgan has one final question to kind of wrap everything up tonight.
Yes. So for everyone on the panel, if there's one, I know we kind of touched on this a little bit earlier too with our patients, but I guess I'm curious to hear if there's any other thoughts or things that you want to share to those who have dysautonomia or who are undiagnosed and are seeking help. I know it can be really hard, as you guys had shared as patients, being on that end, not sure of what's going on and what to kind of do in that situation. And then Dr. Boris, of course, like you being the provider, is there any advice? It doesn't need to be super long, but or recommendations you might have for people who are in that position of not being certain if they do fall into this category. And we can start with Maggie.
I think my advice would be, because it's funny listening to you guys talk about POTS. I'm like, no, those are like almost all the symptoms that I also experience. And I actually was misdiagnosed with POTS at first, before I got the proper AAG diagnosis. So in terms of advice for that, I would say, if your treatment isn't, working quite as well, or if you just feel like something is off and it's just not the right answer, like don't be afraid to keep pushing. And, of course, I'm not saying that, everybody's going to be misdiagnosed with POTS. Like, don't get me wrong one bit, but this goes for all illnesses is, if because I feel like a lot of these illnesses kind of have a Venn diagram of symptoms and what qualifies as what. So just keep pushing for that proper diagnosis, and I feel like you'll really know when you find something that your body is gonna react well to. Like again, like Iman was saying a little bit ago, like your body, you're the only one living in it, and you will know when something feels right or wrong.
Yeah, thank you so much for sharing.
Yeah.
That's super powerful and great advice. And then Aman, if you can go next.
Yeah, I think like a lot of what Maggie was saying about the crossover, like I don't know, with pre-existing conditions or conditions I continue to be diagnosed with, it's really hard. Sometimes you just won't be confident about knowing if it's exactly one thing. Sometimes it will be a combination. Sometimes, like for me, I feel like it's really difficult to just be like, oh, that's just POTS, because then I'm like, well, I don't only live with POTS, so why would it only be just POTS? And I think just reminding myself that even if I see like other people that have this condition, if I relate in any way, it doesn't mean I have to be like to the T with the same person. It's very individualized how people experience it, but like how other conditions you deal with, like if you're type 1 diabetic, other things, it affects how you navigate and even experience the symptoms of those conditions in itself as well.
Yeah, that's a great point. And that kind of goes to what we say also at the beginning of our meetings, that everyone experiences the same condition. They can have the same condition, but experience them differently. And so I think that's a really important point to touch on. So thank you for sharing.
And I'm
Yeah.
so sorry. I wanted to
No,
add
you're
one
good.
more thing onto what they just said. Because like I don't think I mentioned this, but my the AAG actually caused insulin resistance for me, which was what was causing my blood sugars to be all over the place. So it's kind of
Wow.
funny how they can like almost like interact and play off of each other. Like like what Aman was
Yeah.
saying. Like hey, like it may not be just this one thing, like it could be these two things kind of like together. So I just wanted to like kind of mention that that's a really interesting point to bring up, that like hey, you may have found one piece of the puzzle but maybe not necessarily the other piece quite yet. So just keep pushing if again if you things don't feel right.
Yeah, and like Dr. Boris brought up earlier, like there's a lot of conditions that are comorbid with each other. Like a lot of POTS patients have mast cell activation syndrome, a lot have
Yeah.
EDS, a lot have the list goes on, and these things can exasperate each other and just build on each other, or like for you counteract and kind of fight against each other too.
Exactly.
Yeah, definitely 100%. And then Dr. Boris, if you wouldn't mind closing us out here on advice for people who are undiagnosed.
Yeah, I mean, I think I think one of the biggest issues, of course, is finding a clinician who is knowledgeable, and that's hard, right? You walk into a doctor's office and you basically give yourself over, and have to give a lot of trust, and that's hard to do in general, especially to someone you don't know. But then you have to trust that that person knows what the heck they're talking about. um, to try to find a clinician who can do this. The Dysautonomia International website has a list of providers broken out by state, but everyone, as I mentioned before, there's a lot of variability in the way these patients are treated and the way these different providers help to care for them. And so it, I think, um, it's all about fit. It's all about finding somebody whom you do trust. It is certainly finding the right therapeutic approach and somebody who is creative, thoughtful, knowledgeable enough to sort of say, oh, this isn't POTS. I wonder if this is AAG, for example, right? Um, or yeah, you have POTS, and we know that neurocardiogenic syncope can occur in the setting of POTS, but what things can we do to help further reduce your syncopal episodes so that you can be functional, right? I mean, those kind of things um, are really important.
Thank you so much again for sharing, all of you, and all of you talking about your experiences and what it's like to be a provider or to be a patient. This is super, super helpful and super, super valuable. I know that we are definitely over time, so apologies about that. And thank you all for staying on and chatting with us. I just want to go through a couple of quick announcements and then we'll go ahead and wrap up the chat real quick. We do also have a few messages though in our chat in case you guys are available to hang around a little bit once we end the call. But if you got to get going, you're more than welcome to leave. But I did just want to go ahead and make a couple of announcements. Please go to our YouTube channel to watch our previous guest speaker events. We will also be posting this video on there as well. So keep an eye out for it, and you can follow us on social media or visit our website to get access to those details for the link and everything, as well as subscribe to our newsletter. And we are also always looking for new volunteers and people who are interested in becoming a guest speaker. So if you're interested in either way, so being a speaker, know someone who could be a speaker, or you are loving what we're doing here and you want to contribute to the nonprofit, that would be amazing. Our email address is info@iinetwork.org. And as I mentioned, please follow us on Instagram to see when we're going to be announcing our November event. For that event, we're going to be covering circulatory conditions. And then our last slide, once it up, is just our credits as well. So again, that's going to be our social media, so our Instagram and YouTube, as well as our website. And then please scan that QR code to get access to all of these informations. The Instagram handle, we have two of them. The first one is invisible_illness_awareness. And then if you want to follow specifically the Invisibly Aware series, which again is what you're attending tonight, that's going to be at invisibly_aware_ oh, sorry. I might have said that wrong. Invisible_illness_network. And then we have invisibly_aware_series. But again, if you scan that QR code, you will gain access to all of our websites and our social medias. So thank you so much again to our incredible guest speakers. And thank you for everyone who joined today's call to hear from these incredible people.